times I'm in Jakarta. My topic today is principles in the diagnosis and management of pituitary Cushing's. I'll be sharing some tips and pitfalls, which are areas we can slip and fall if we are not careful. Maybe I like to show this model. This is a maze that I'm applying it to Cushing's. If you have a patient with Cushing's, as you can see over there, and you want to take this patient through a process of diagnosis and then localize where is the tumor producing the excess cortisol and hopefully cure the patient in stages, of course, milder form of clinical manifestations back to a normal manifestation. So you go through a maze, but this maze is difficult. It has 3 doors. You have to choose the right door to come out. And one door leads you to adrenal Cushing's. The next door leads you to ectopic Cushing's. And the third door leads you to pituitary Cushing's. If you follow the right track, you cure the patient. And surgery is the best cure for this patient. There are lots of difficulties in the process, so you have to catch the right culprit, if you like. You do it wrong, the patient suffers, we get trapped. And we have been trapped time and again. In discussing this topic, I thought I'll cover 5 areas. I'll go in steps before I reach the target. And that would include diagnosis of Cushing syndrome in itself, the diagnosis of ACTH-dependent Cushing's, and then confirmation that it is pituitary Cushing's. We manage the Cushing's disease. I will touch a little bit on management of comorbidities. At every stage, as you climb the stairs, one can slip. That is where one has to be careful. So let's deal with the first aspect. The first thing, exclude exogenous Cushing's. It's no point evaluating if it's exogenous Cushing's because that's a totally different problem. And then the Endocrine Society recommends if there are unusual features for age, progressive features, changes, patients with incidentaloma, pituitary or adrenal, and particularly in children where there's a disproportion between height and weight. Perhaps we can add the patient's complaints are still important. And there are some discriminatory signs. How do we know somebody is obese and how do we know somebody has Cushing's? So I'll be touching a little bit about this. In talking about exogenous Cushing's, I think there are 4 important aspects that we often have to ask and ask repeatedly. The patient may tell you they have SLE on steroids, gout, asthma. They may not tell you, they may take traditional medication, but one needs to probe for that. Sometimes we may think it's not important, but in susceptible individuals, creams, eye drops, intra-articular injections. Occasionally, patients deny they're taking steroids. So the clinical features of exogenous steroids are usually more striking. They have less hypertension. They tend to have less hirsutism and virilization. Cataracts, avascular necrosis is commoner. I'll move a little bit into statistics so that we understand. If that's a group of patients with Cushing's, and that's a group of normal patients, normal versus Cushing's, there is an overlap. This is, for example, early Cushing's. This could be simple obesity. If we had somebody with borderline symptoms, it becomes difficult. So we have true positive and true negatives. If you have a test that's 100% sensitive, you can clearly distinguish the non-Cushing's from the Cushing's. If you have a test that is 100% specific, you can distinguish Cushing's from non-Cushing's. So this helps to rule out a disease. This helps to rule in a disease. How can we use this data clinically? Based on studies, if you see the green, if the patients do not have these, you tend to rule out Cushing's. If they have this, you're almost sure to deal with Cushing's. So the good signs that make you suspect this is Cushing's are the signs of protein catabolism. That's the easiest way to remember. There's diagnostic accuracy of signs, and you can go by probability. Likelihood ratio can be positive or negative. Over here, you see those that help you think whether the patient may have Cushing's or not. And when you see the signs on the right-hand side of your slide, I want you to pay particular attention to skin fold thickness. A thin skin has a very high contributory value in the clinical evaluation of Cushing's. So, if you go pathophysiologically, we have a feedback mechanism. We have variations in our daily cortisol. In patients with Cushing's, both are lost. Therefore, you can't use a random cortisol to diagnose Cushing's. You confirm Cushing's either by blood tests, urinary tests, or more recently, salivary cortisol. We don't have it routinely in Singapore. Very quickly to touch on this, the oral 1 milligram dexamethasone screening test, good screening test, but a better test, the old gold standard, is to do a low dose 0.5 milligram 6-hourly test. So that's a good rule out test. You're not sure, you do the test, negative, you say unlikely Cushing's. There are false positives, there are false negatives. It is worth knowing it. As far as urinary test is concerned, I showed you this curve before. Integrated assessment of cortisol, that's normal. In patients with Cushing's, you see a larger integrated cortisol overall. It's not affected by cortisol binding globulin. Of course, it depends proper collection. And once you see more than 4 times, you're almost assured that you're dealing with Cushing's. But sometimes they may have a normal cortisol. If you do 4 tests in one patient, one may be perfectly normal. So a normal 24-hour cortisol urinary does not exclude Cushing's, but most of them have it elevated. These are some false positive related to fluids, urinary outputs, drugs, the methods you measure them. salivary cortisol is not routinely available, but it's convenient. Diagnostic accuracy is good. Interpretation may be difficult in those who do shift duties, contamination of samples, illnesses where there's activation of the cortisol system, licorice users, tobacco users. So look at this test. Sensitivity in blue for the different tests. Specificity in brown for the different tests. So it's useful to know the best rule-out test is over there. For early recurrence, salivary cortisol seems to show good results. Beware that some patients have cyclical Cushing's. One day they might have Cushing's, the next day they might not have. But clinically, you don't know which manifestations depending on how long they have. There are some special situations like pregnancy where urinary free cortisol is normally elevated. In renal failure, urinary free cortisol values are decreased, so that gives a problem. In epilepsy, drugs can metabolize dexamethasone. I mentioned about cyclical Cushing's. It's an on-off phenomenon. And in incidentaloma, a dexamethasone suppression test is more reliable than a urine-free cortisol. So if you think of Cushing's as a model, it depends on symptoms, it depends on biochemical findings. The patient with iatrogenic has deficiency but clinical features of Cushing's. That's a classic Cushing's. Biochemistry and clinical are concordant. That's a patient who has no Cushing's. Clinical, biochemistry, concordant. That's a difficult situation. That's the atypical situation where they have biochemical Cushing's, but very little clinical Cushing signs. And that is pseudo-Cushing's. Example, alcoholism, depression. I'll go to the second part now, which is diagnosis of ACTH-dependent Cushing's. And we typically classify pituitary or eutopic, ectopic, or adrenal Cushing's. Worth knowing some common facts. The commonest cause of endogenous Cushing's is pituitary Cushing's. The commonest manifestation is in females to males ratio approximately 3 to 5:1. Ectopic tumors, there can be slow growing, benign, or malignant, fast growing. And paradoxically, they may even have weight loss. You would never think of Cushing. But they tend to be older age group, commoner in males. Cushing's can be delayed in diagnosis. This is a more recent publication. It seems we pick up ectopic much earlier, 14 months. We take longer to diagnose pituitary Cushing's because they are slow and evolving. Think in terms of ACTH levels. Adrenal Cushing's, very low ACTH levels. Pituitary Cushing's can be normal, can be high, rarely very high. Ectopic Cushing's, usually very high, but sometimes can be lowish. So, the ACTH levels will help you. Of course, if the ACTH levels are high, the pigmentation is increased, And they may get hypokalemia, they may get metabolic alkalosis. So beware of ACTH assays. We commonly do by ECLIA or ELISA. The long form is that. You have to take the samples, chill tubes, refrigerated centrifuge. RIA assays not as reliable. There may be episodic secretion, so we do 2 samples, and that's the gold standard method, mass spectrometry. So now I come to the third point, confirmation of Cushing's disease. So you have to confirm that rather than ectopic sources. We have 5 useful tests. The high dose, CRH, MRI pituitary, bilateral inferior petrosal sinus sampling, BIPS for short. And then you can go on to a pan CT scan, octo scan, PET scan. Let's deal with the first one. Adrenal tumors and ectopic tumors have full autonomy. They don't follow physiology. Pituitary tumors are semi-autonomous. If you use a high enough steroid dose, they suppress. That's the basis of this test. The original Liddell's test looked at basal values, and when there's suppression to 50% below basal values, it suggests pituitary. They changed it to the urinary cortisol, and now people talk about plasma cortisol, and some shorten it by 8 milligram overnight dexamethasone suppression test. Anything more than 50% suppression, we tend to diagnose pituitary, less than 50% adrenal or ectopic. But this test is only sensitive 80%. In females with Cushing's, you tell me a female patient coming to see me with Cushing's disease, even before she enters my door, I say most likely this is pituitary, 80% chance. So I already have a pre-test probability. So some people question, how does this test help you if it's only 80% accurate? So not routinely recommended by everybody, but a lot of us still do this test. There's a CRH test. CRH is increasingly difficult to obtain, but maybe a little physiology will help us. When you inject CRH, that's the normal range in elevated cortisol. Pituitary Cushing's responds by a rise in CRH. Ectopic Cushing's show no changes with CRH. So these are some of the criteria proposed. If it rises more than 20% in cortisol or more than 50% in ACTH, you tend to think of pituitary Cushing's. Some have added accuracy to this by doing a simultaneous dexamethasone suppression test. But it's a new problem. CRH is not globally available. Some have started to use desmopressin. Experience is limited. I want to move on to MRI, and MRI identifies pituitary tumors in less than 50% of patients. That's 1.5 Tesla MRI. If you use a 3 Tesla, maybe more may be identified. But 10% of normal individuals have an MRI demonstrable tumor. So 10% of us. I haven't had an MRI. Maybe I have. Okay. So they say a lesion less than 6 millimeter. That's not reliably identify Cushing's as a cause. And should we do routine BIPs? The recommendation is if the tumor is more than 10 millimeter, you don't need to do it. If the tumor is less than 6 millimeter, probably useful to do it. This is inferior petrosal sinus sampling. You do sampling on both sides. CRH is given if available. Blood sampling from all three catheters, including peripheral, and a central to peripheral gradient more than 2 or 3 if it's CRH. And ACTH ratio is not very useful to localize left or right tumor, so tread with caution. DDAVP has been used. Clinical experience suggests it's like CRH. Prolactin measurements have added value. It improves sensitivity, and false negative is reduced. Those are reasons why BIPS is never accurate. Can't localize it still. We go on to PAN-CT, octreoscan, PET scan. If you find something on CT, MRI, good. If you can't, you can go on to further tests. So the outcome, 2 possibilities. You find an ectopic tumor or indeterminate tumor, and then people follow up image. So 5 important tests to confirm. Let's go to management. Preoperative, surgery, postoperative, assessment for cure. You have to localize a good pituitary surgeon. If on ketoconazole, perhaps steroids. Care with positioning. These patients have osteoporosis, they can get fractures. If surgery is prolonged, intraoperative steroids. Tell your patients they're going to feel worse if they are cured. It sounds paradoxical, but it's the truth. Because they are not used to such low level of steroids if they are cured. Review the pathology. Sometimes we fall into this. So we can have pituitary directed treatment, drugs, radiation, adrenal directed treatment, bilateral adrenalectomy, or drugs for adrenal, and more recently, glucocorticoid receptor antagonists. We heard about AI. Increasingly, AI is being used. So these are some papers talking about AI. It's a new kid on the block. It'll become more prominent. Cushing's disease is associated with increased mortality. We showed it in the New Zealand population many years ago. And this is a more recent publication. Look at the mortality ratio. If it's active Cushing's, greater mortality compared to those in remission. Macroadenomas, more mortality compared with microadenomas. This talks about comorbidities. You see the whole list there. You have to manage them. And after treatment, not all improve, but they do improve. But we need to focus our attention. These are 4 patients with Cushing's, 58-year-old female, MRI, cyst, BIPS done, showed left pituitary. You see a tumor. Female, BIPS done again, 3 transsphenoidal surgery. Male, no BIPS done, and female, 2 surgeries done for a tumor. Look at the outcome. Cured, not cured, cured, cured after second surgery. So when we deal with patients with Cushing's, there's always uncertainty. And the ultimate success is to cure them. But for those who have never been surprised, I think we probably need to see more. Let's go back to this. When there's clinical Cushing's, ask yourself, is it pseudo Cushing's? If it's pseudo Cushing's, exit the door there. Don't go through this maze. If it's not, you're allowed to go. And then you think endogenous or exogenous. If it's exogenous, exit the door there. If it's endogenous, go ahead, do tests. If the tests are negative, exit the door. My time's up. I'll just take a few more minutes. You assess biochemical Cushing's. Then you decide ACTH dependent or independent. If it's independent, exit the door of adrenalectomy. If not, do further tests. If it's ectopic, surgical excision of the ectopic. If it's pituitary, get your good neurosurgeon and go for surgery and you cure. So, in summary, confirm the diagnosis first. Then you think of the cause, not the other way around. Biochemistry first before radiology, not the other way around, because they are incidentalomas. Whenever you do tests, be careful. Sensitivity, specificity, false positive, false negative. Once in a while, you are trapped by cyclical Cushing's. I'm not sure you all remember this game, Pac-Man. Can't get the sound there. But you need a lot of experience to play Pac-Man. Most of the time you can win with experience, but once in a while you get trapped. So with that, I thank you very much.